Another valuable test that we do in patients with anemia is we can actually look at the blood under the microscope. And the blood under the microscope, it's hard to say whether the blood cells are small or big or have a normal distribution. That's what the machine is for. But the blood cells can give us clues as to what's going on. So you see this picture here. This is a patient who's having an acute hemolytic anemia. That's an intravascular problem. They've got helmet cells, and cells are being clearly ripped apart. Here's an example of a patient with a multilobular white blood cell. That's going to tell me a little bit that this patient may have B12 deficiency. Here's another example of where the picture might help us. Look at this slide carefully and you can see, especially on the top right next to that one, little purple dots. This is called basophilic stippling. We sometimes see this in lead poisoning. So if I saw this under the microscope, I'd know, uh-oh, better worry about lead poisoning. Here's another example of a picture. This patient has very abnormal shaped cells. So here's a last one. This one should be pretty obvious to you. If you look at it carefully, you can see that some of the cells are long and thin instead of round. Yeah, this person has sickle cell disease. And you can see it if you step back even, if you look at the farther away view, you can see lots of little sickled cells. Even looking at the smear might tell you how bad off they are right now, how much sickling is going on. Okay, so we've got a CBC, we know their reticulocyte, and we know their MCV. And we have a sense of the RDW as well. Let's break it down in terms of what might be going on. So I got a CBC in this patient. They had a high reticulocyte count. They're making lots of red blood cells, but they're microcytic. This is going to be a thalassemia. It's a chronic, indolent problem where the hemoglobin doesn't quite work right and it breaks down easily, but they're trying to make more. If they have a high MCV, it's big cells, this might be a membrane disorder, or they may have G6PD, or an autoimmune disease, or a sickle cell disease, or a hemolytic uremic syndrome. Perhaps they have DIC, or disseminated intravascular coagulation, or they could be suffering from chronic blood loss. We'll use our history to start to get into this, or if we're still unsure, we can do some tests to make sure. For example, for sickle cell disease, we could easily check a hemoglobin. Or for G6PD, we could look for signs of G6PD on the smear, or we can get a history that'll clarify that, or we can test for the enzyme. Now, here's a CBC with DIF where we're going to have a low or a normal reticulocyte count. In other words, this patient's not cranking out cells. They have a low MCV. They might have ongoing iron deficiency. It's hard for them to make reticulocyte counts, so it's low. They may have lead poisoning or a thalassemia trait, or perhaps anemia of chronic disease. If they have a large cells, once again, they may have aplastic anemia, transient erythroblastopenia of childhood, sickle cell disease, membrane disorders, or autoimmune disease. You can see how these values are going to start to tweak our understanding, our guessing of what things are, and if you understand the disease, you'll be able to put it together. So knowing that lead poisoning causes microcytic anemia and is a long indolent thing and prevents the production of reticulocyte counts, you can predict where it falls in this table.